In the past, people who were acutely suicidal or actively suicidal, or who even had a history of a prior suicide attempt, were systematically excluded from treatment trials. And so we developed this entire literature, for example, on antidepressants, about what works for depressed people who are not suicidal. It was those of us who were doing research who wanted to do intervention trials to see what worked for suicidal individuals that stepped up and said, you know, we really need to find out not just what works in depression for the non-suicidal, but what works specifically for people who are suicidal.
We've often heard from families who've lost somebody to suicide. Added to that voice now are people with lived experience, people who've attempted and survived, who can tell us a little bit more about their trajectories and their experience with healthcare and how we can improve things. How cancer has had better survival rates, how HIV now perhaps has a treatment. All those came from investments that were demanded by patients.
With some funding from AFSP, one of the things that we have done is to much more deeply integrate people who themselves have lived experience of suicidal thinking or suicide attempts into our research team. That's been a real eye-opener to us. This is a challenging area to work in. We really have to be very mindful and respectful of each individual's experience. We do a lot of work on outreach interventions. Up until a few years ago, there certainly were people with lived experience of suicidal thoughts who were involved in this research, but they often were not out about it. And I think that's been a really important development in terms of even some people who are researchers in the field being out about their own experience, but also the idea that having people with that lived experience on research teams is a key asset.